Subcommittee will come to order. As agreed earlier with the Democrat side of the aisle, each side will be recognized for 1 minute for opening statements. Then we can move straight to Secretary Sebelius' testimony and questions. The Chair reminds the members that pursuant to the committee rules, all members' opening statements will be made part of the record. The Chair recognizes himself for 1 minute for an opening statement. First, I'd like to thank Secretary Sebelius for being here with us today to discuss the fiscal year 2013 budget. One of the most striking features of this year's budget is just how much of it is not dependent upon Congress. For example, the phrase ACA mandatory funding appears throughout the budget tables, and this designation means, of course, that the Affordable Care Act requires automatic appropriations for certain items. The phrase prevention fund also appears numerous times, referencing the Prevention and Public Health Fund, a multi-billion-dollar fund over which the Secretary has sole discretion. Beyond the absence of congressional authority over these funds, I'm deeply troubled by the lack of accountability and transparency practiced by the Department, and I hope the Secretary will be able to explain why her department is so late on so many of the rules required by PPACA. Chair now recognizes the ranking member of the subcommittee, Mr. Pallone, for 1 minute for opening statement.
Thank you, Chairman Pitts and Secretary Sebelius, for being here today. I know I have to limit my remarks, so I just want to say with regard to the Affordable Care Act, I think we're making a lot of progress, and I certainly urge the President and the Secretary to continue taking the steps necessary under the ACA to improve our health care system. But I'm also a strong believer in the importance of government investment in advancing science and research. That's why I was also pleased to see the President's continued support towards innovative biomedical and behavioral advancement through investments in the NIH and the FDA. I was also pleased to see that the administration has proposed an expansion of the small business health care tax credit that could benefit almost 4 billion workers this year. My state of New Jersey has a high cost of living and a high wage base, which has made it tougher for New Jersey small employers to access this tax. I'd like to see the wage base in each state included in the calculation for eligibility of the tax credit, and therefore I'm planning on introducing legislation that would remedy this issue, and I hope I can work with HHS on this. So thank you, Madam Secretary, for being here. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Our witness today will be the Secretary of the Department of Health and Human Services, the Honorable Kathleen Sebelius. Secretary Sebelius, we're delighted to have you back with us today, and you're recognized for 5 minutes for an opening statement.
Thank you so much, Chairman Pitts and Ranking Members Pallone and Waxman and members of the committee. I'm pleased to be with you today to discuss the President's 2013 budget for the Department of Health and Human Services. Our budget helps to create an American economy built to last by strengthening our nation's health care, supporting research that will lead to tomorrow's cures, and promoting opportunities for American children and families so everyone has a fair shot to reach his or her own potential. It makes investments that we need right now while reducing the deficit in the long run to make sure that the programs that millions of Americans rely on will be there for generations to come. And I look forward to answering your questions, Mr. Chairman, about the budget, but I want to just take a few minutes to share some of the highlights. Over the last 2 years, we have worked to deliver the benefits of the Affordable Care Act to the American people. Thanks to the law, we now have 2.5 million additional young Americans already getting coverage through their parents' health plans. More than 25 million seniors have already taken advantage of the free recommended preventive services under Medicare. And small business owners are getting tax breaks on their health care bills that allow them to hire more employees. This year we'll build on that progress by continuing to support states as they work to establish affordable insurance exchanges by 2014. Once these competitive marketplaces are in place, they'll ensure that all Americans have access to quality, affordable health coverage. But we know that a lack of insurance isn't the only obstacle to care, so our budget also invests in our health care workforce. The budget supports training more than 7,100 primary care providers and placing them where they're needed most. It also invests in America's network of community health centers. Our budget helps health centers provide access to quality care for 21 million Americans, 300,000 more than were served last year. This budget also continues the administration's commitment to improving the quality and safety of care by spending health dollars more wisely. And that means investing in health information technology. It means funding the first of its kind CMS Innovation Center, which is partnering with physicians, nurses, private payers, hospitals, and others who've accepted the challenge to develop new, sustainable methods for the healthcare system. In addition, the budget ensures that a 21st century America will continue to lead the world in biomedical research by maintaining funding for the National Institutes of Health. At the same time, we recognize the need to set priorities, make difficult trade-offs, and ensure we use every dollar wisely. That starts with continuing support for President Obama's historic push to stamp out waste, fraud, and abuse in the healthcare system. Now, over the last 3 years, every dollar we've put into healthcare fraud has returned more than $7. That's a pretty good investment. Last year alone, those efforts recovered more than $4 billion, which are both in the Medicare and Medicaid trust funds around the country. And this week, our administration arrested the alleged head of the largest individual Medicare and Medicaid fraud operation in history. Our budget builds on those efforts, giving law enforcement the technology and data to spot perpetrators early and prevent payments based on fraud from going out in the first place. The budget also contains more than $360 billion in health savings over the next 10 years, most of which comes from reforms to Medicare and Medicaid. These are significant, but they're carefully crafted to protect beneficiaries. For example, we propose significant savings in Medicare by reducing drug costs, a plan that not only reduces the costs of pharmaceuticals, but puts money back in the pockets of Medicare beneficiaries. The budget makes smart investments where they'll have the greatest impact, and it puts us all on a path to build a stronger, healthy, and more prosperous America for the future. Again, thank you, Mr. Chairman, for this invitation, and I look forward to our conversation.
Chair thanks the gentlelady, and we'll now begin questioning, and I'll recognize myself 5 minutes for that purpose. Regardless of one's opinion of the healthcare law, I think everyone can agree there is a lot of regulatory uncertainty regarding the rules of the road moving ahead. States, health providers, small businesses, and patients have been asking HHS for final or even just proposed federal rules as they relate to PPACA's exchanges. The stakes are high since taxpayers are on the hook for a new $1 trillion entitlement. With that in mind, I'd like to ask you about the status of PPACA rules required by the statute. And given my limited time, I'd respectfully ask that you answer yes or no. I have a series of questions. First, has HHS released a final rule as it relates to the individual market exchange?
The state-based market exchange, a final rule? No, sir.
Has HHS released a final rule detailing what states must do to receive federal approval for their exchange?
We have not issued a final rule, sir, but we have certainly put out bulletins and guidance. We are preparing an interim final rule. We want feedback at every point along the way, and we are actively working with states around the country
But a bulletin has no real guidance for the state. You have not proposed a final rule.
We have not proposed a final rule, sir, but they have a lot of guidance and are very actively engaged in the process of helping us shape the final rules.
Thank you. Has HHS released a final rule related to the establishment and operation of a federal exchange?
Again, no, Mr. Chairman, but we are in the process. I don't think you'd want us to do that without actively engaging stakeholders along the way, and that's exactly what we're doing, including the last weekend when the governors were in town and we spent hours with state officials talking about
So the answer is no. Has HHS released a final rule related to federal accreditation requirements for health plans?
Regarding, I'm sorry?
Federal accreditation of health plans. For health
accreditation. No, sir.
Has HHS released a final rule related to guaranteed issue and community rating bans?
We do not have the final rules released at this
Has
point.
HHS released even a proposed rule for cost sharing or federally mandated benefits, otherwise known as essential health benefits?
We have released guidance. Most
bulletin.
recently, we are talking to states about what the interim final rule. We've given them
But
a
not a final
strategy for
rule.
the benchmark plan, and we are
understand that.
preparing the rules as we speak, Mr.
No
Chairman.
final rule. The federal requirements on benefit coverage and cost sharing are two of the most basic and critical pieces of information needed for states to implement an exchange. We're less than 18 months from when plans are supposed to enroll customers in exchange plans. Has HHS HHS has not even issued a proposed rule on these fundamental pieces of law. Is that correct?
Mr. Chairman, again, we are actively engaged in benchmark plans. We have released guidance. We're getting input on that. We're trying to make sure that when we release an interim rule and when we move to final rules, that these are workable arrangements with states, with markets around the country. So that guidance is very much underway. We're engaged in dialogue, and
I understand.
They're beginning to frame their plans.
My
But we would
time's
agree
limited.
that we
Let
need
me-
rules
let me
to
continue.
monitor the.
I would submit this is symbolic with the state of regulation in Washington. States, small businesses, and individuals are shoved aside and told that a federal agency is needed to meddle around in their lives, and then we pass a law giving Washington almost universal control over 1/6 of the economy, and then Washington writes some vague rules for some parts of the law and delays rules for other parts of the law. Deadlines are not met. States, healthcare providers, and consumers are left in the dark, and Washington thinks it can just dump 1,000 requirements on states in the private sector at the last minute with no consequences for patient health. I have just 35 seconds left. Yesterday, I was contacted by Catholic Charities, and I was asked if I would read into the record their actual position on this so-called accommodation, because they believe some have mischaracterized where they stand. And upon the announcement of the so-called accommodation, Reverend Larry Snyder, President and CEO of Catholic Charities USA, stated, quote, "Catholic Charities USA welcomes the administration's attempt to meet the concerns of the religious community, and we look forward to reviewing the final language. We're hopeful that this is a step in the right direction. We're committed to continuing our work to ensure that our religious institutions will continue to be granted the freedom to remain faithful to our beliefs while also being committed to providing access to quality health care for our 70,000 employees and their families across the country." However, upon actually seeing what was proposed and having their position mischaracterized as if they believed the accommodation was sufficient to protect religious liberty, they posted the following clarification, quote, "In response to a great number of mischaracterizations in the media, Catholic Charities USA wants to make two things very clear. One, we have not endorsed the accommodation to the HHS mandate that was announced by the administration on February 10. Two, we unequivocally share the goal of the U.S. Catholic bishops to uphold religious liberty and will continue to work with the U.S. CCB towards that goal. Any representation to the contrary is false," end quote. Now, the Chair recognizes the ranking member, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. And Madam Secretary, I apologize, but I have to try to get in two questions, one on the children's graduate medical education and the other is on cosmetic user fees. So if I cut you short on the first one, it's only because I want to get to the second one. I want to say I'm pleased that the administration has come to its senses and included funding for the Children's Hospital Graduate Medical Education, or CHGME, in this year's budget. However, I'm dismayed that the White House only proposes $88 million, approximately 1/3 the amount which Congress appropriated for the program last year. As you know, there are serious national shortages in many pediatric specialties, shortages which the CHGME program has been crucial in helping to address. Children's Specialized Hospital in New Jersey has told me that significant reductions to the program would exacerbate these shortages and create additional barriers to access to specialty care for children. So I wanted to ask you, if the CHGME is not adequately funded, which obviously I don't think it is, how do you expect to train these providers, not only for the shortage in primary care pediatrics, but also in the specialties, if, you know, with this level of funding, essentially?
Well, Mr. Pallone, we have had this discussion before, and I know we share your interest in training of primary care providers, and particularly pediatric providers. There are other streams of funding available. We are trying to use what are relatively limited resources to focus on a broad array of primary care training programs, and in a better budget time, we clearly would have proposed additional resources, but this reflects tough decisions made at a very difficult time.
No, and I appreciate that. I just wanted to stress that I just don't think the investments in the pediatric specialty loan repayment program alone will be enough to compensate for the cuts. And I know that the budget eliminates the IME costs and only funds the direct medical expenses for pediatric GME. But the problem is, and again, I'm very conscious of this, and I'm not saying this to you personally, but I always think that we worry about adults, particularly senior citizens, and then at the same time, we're not, doing what we should for kids. And so the administration has not proposed to completely cut the IME funding for adults in the Medicare population, but eliminates this funding that directly benefits the health of kids. And it just seems like the kids are always taking the back seat. This is not just here, it's in so many other aspects of the budget. And I just think the consequence of that is that, we're really going to threaten the already vulnerable pediatric healthcare workforce. But let me get to my second question on cosmetic user fees. The President's budget for the FDA includes a proposed new user fee that would address cosmetic safety, and that fee would cover activities relating to the establishment of registration fees, set cosmetic standards, and refine inspections and sampling of imported and domestic products. You know that myself, Mr. Dingle, and Mr. Waxman have been working on a proposal that would require registration of cosmetic facilities and listing of products, requiring substantiation of the safety of cosmetic products, requiring adverse event reporting, and giving FDA the authority to recall cosmetic products. It's obvious the administration agrees that the cosmetics program is in need of resources because your budget includes fees for activities like registration and standard setting. But if we were to adopt my proposal and add on more responsibilities in the cosmetic area, do you agree that there would be an even greater need for additional fees? That's my question.
Mr. Pallone, we do share your interest in this important area. I think the fees in the budget would support, according to the FDA, a cosmetic registration program. We'd be very eager to work with you looking at other areas that might be appropriate, but reluctant to do that without additional resources, giving the FDA lots of assignments without the resources to carry them out effectively. But this is an area that I think needs attention, which is why the President has proposed the cosmetic registration program. It would allow us to implement and standardize and collect information that just isn't available right now for consumer safety.
And I appreciate that. I mean, we all want the FDA to do a good job ensuring the safety of cosmetic products, and I think it's critical that we ensure that they have the resources to do it, and I appreciate your...
And we would be eager to work with you to do that.
Thank you. Thank you, Mr. Chairman.
Chair, thanks to the gentleman, and now recognize the Chairman of the full committee, Mr. Upton, for 5 minutes for questions.
Thank you, Mr. Chairman. Welcome, Madam Secretary. A couple things that I'd like to ask this morning. I am seeing different numbers in the 2013 budget than the spending levels that you provided to the committee a year ago. And I don't know if you want to respond by letter in response back, but let me just walk you through a couple things. Last year, you stated that HHS was estimated to spend $400 million on state exchange grants in fiscal year 12, but according to your latest budget, your department will have spent $900 million plus on these very same grants in fiscal year 12, more than double your estimate from a year ago. Is that correct?
Mr. Chairman, we have spent so far out of the allocation 2 years ago of $1 billion, about $475 million, and 261 of that has been spent by HHS. That's
this is specifically the state exchange grants.
Oh, the state exchange grants.
You might you might want to come back to us in a
And I'd be
letter.
happy to get, I want to
I
make sure we get all these details
As
to
a
you
former
correctly.
budget official, I can we'll put this, we'll look forward to a written
Certainly.
response. Now, Congress in the President's Health Care Law appropriated $1 billion for the implementation, yet in this year's budget, you're estimated that the fund will be exhausted by the end of 12, and you've asked for another $1 billion to implement the law. Is that correct?
Yes, Mr.
Yes.
Chairman, and that's the question I was answering. I apologize. We had an original $1 billion in the Affordable Care Act when it was passed.
And now it's 2.
Pardon me?
And now it's 2.
Well, the CBO estimate in March of 2010 was that it would cost about $1 billion a year to implement. We have actually well underspent that estimate. So we are now in FY 2012. We have spent at HHS about $261 million, a total with our other agency partners of $475 million, but we think by the end of 2012, that original $1 billion will be spent and 2.5 years will have expired. So we are significantly underspending what the estimates were.
Let me put this then in writing, and let me point some of these out. I want to get to a
great.
question as it relates to my state and my district. This committee, we received a memo from CRS, Congressional Research Service, outlining possible penalties for religious employers if they failed to comply with the HHS mandate to cover drugs and services that they have a religious or moral objections toward. And according to CRS, those penalties of $100 per day per affected individual could be levied against the institution for following their conscience. In my state, we have, and in my district, I have a hospital, Borges Hospital, a pretty large institution. It is part of the Ascension Hospital system in Michigan. They employ, throughout the state, 31,000 people. So according to the CRS memo, Ascension is likely to be subject to fines of over $1 billion, that's B as in big, because of that mandate. So my question, and Ascension, like many religious affiliated organizations, in fact, is self-insured. So the so-called accommodation announced by the White House on February 10th doesn't attempt, as I understand, to address the violation of conscience against self-insured employers. So what are your plans for accommodating self-insured employers with conscious issues like Borges Hospital?
Mr. Chairman, the accommodation that the President talked about on the 10th of February would apply to the non-exempted employers who currently do not offer contraception because of religious objections. As you know, churches, church auxiliaries, we think many parochial and Catholic elementary schools and high schools are likely to already be totally exempted. Grandfathered plans are totally exempted. The accommodation
So schools are totally exempted?
If a parochial school meets the definition that's in the IRS, where they have a majority of Catholic employees, serve a majority of, or religious employees, serve
So
a
how would
majority
this
of
impact an institution like Borges Hospital?
Well,
essentially?
I'm getting to
Right.
that, Mr. Chairman. So the rule that we intend to propose, we will propose a rule in the near future after reaching out and having dialogue with folks. It would require insurance companies in a directly insured plan to provide contraception coverage so that a religious employer who had objections would not have to either pay for or provide or refer people for contraception. We are confident that similar arrangements can be made with self-insured institutions who work with third-party administrators. There is an independent body outside the board. There are a variety of arrangements already in place in the 28 states that have this law already in place, and we intend to be informed by that when we propose the rules. So whether it's through a third-party administrator, which would not be the employer group, or a side-by-side plan as operates in Georgetown, or many other hospital arrangements, we will offer a variety of strategies to make sure that religious liberties are respected at the same time that millions of women who work in these institutions and spouses of employees and daughters of employees have access to these important health benefits.
I know my time has expired, but I'm not sure that that's going to work, but I yield back.
Chair, thanks, gentlemen. We are voting. We're going to go one more 5-minute and break and come back immediately after the vote. Chair recognizes the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you very much, Mr. Chairman. Madam Secretary, welcome to the committee. I must say, in the decades that I've been in the Congress, you are one of the finest secretaries we've had for Health and Human Services, and I'm somewhat amused at the questions you're going to get and have already gotten today, because you almost can't win. If you came in with the rules and regulations and spelled them out, you'd be criticized for dumping a lot of regulations on the table without consulting. And now that you're consulting, you're being criticized for not having the rules already in place. I know there's a lot of work to be done leading up to 2014 to create a transparent and competitive marketplace where consumers will be offered quality insurance products that cover their health care needs. Insurers, consumer groups, states, and others have been encouraging the administration to share their thoughts early to allow for maximum planning and preparation. I recognize the need to share information early. I also recognize the need to work through issues thoroughly. That's why I was pleased with the issuance of sub-regulatory guidance on the formation of the Essential Health Benefits Package and on the actuarial value and cost sharing in qualified health plans. This starts the conversation early, allows for input before more formal and lengthy rulemaking is released. But you have been criticized for this decision wrongly, in my view. Can you tell us what you see as the advantage of this approach and confirm whether you intend to continue towards formal notice and comment rulemaking process?
Mr. Waxman, I think you've spelled out what has been part of the strategy, which is to actually put in place rules around framework issues where states need to know. So we do have proposed rules in answer to the chairman's questions earlier around the exchange setup. We have proposed rules for Medicaid expansion, both of which were informed by active conversations from the states. We have now put out a lengthy guidance on a strategy toward the essential health benefits and are having many conversations trying to reach the balance between affordable coverage and comprehensive coverage, making sure that we are mindful of the law, but know that having a product priced and able to be operated in a state is also an essential piece of the puzzle. So we fully intend to put out interim rules and final rules you can't enforce without final rules in place, but we want to be informed by state insurance commissioners, employers on the ground, our colleagues in governor's offices across this country, and that dialogue is very
Well, that sounds like to me a very reasonable approach. This hearing is about the budget, although you're going to be asked about everything. But the budget includes important funding to ensure effective administration of Medicare, Medicaid, child health program, continued implementation of the health care law. The budget request includes an increase of $1 billion over the fiscal year 2012 level. That includes a request for $864 million for establishing insurance exchanges in the states. Now, it's essential that Congress meet the President's budget request. Some of my colleagues may wish to deny your agency this funding in an effort to halt the progress of the health reform law. I think this political approach would jeopardize all the progress we've made. More than 2.5 million young adults under the age of 26 now have health insurance under their parents' plan. More than 85 million people, including those in Medicare and private health insurance plans, have access to free preventive coverage. More than 30 states have begun to plan health exchanges, helping make food on the promise of the affordable coverage for all. And more premium dollars are going to health benefits, not corporate overhead. So this will help consumers get the value for their dollar. Can you address the critics that are claiming that your budget request for implementation money for the Affordable Care Act is a wasteful overspending by the government? Can you describe the kinds of initiatives that money will be used for?
Well, Mr. Waxman, the additional $1 billion in Medicare and Medicaid is for really two categories. One is about $800 million that actually is for the one-time build-out of the federally operated exchange program, IT, consumer outreach, the variety of services that will be needed for those areas in the country where the state has chosen not to set up a state-based exchange or wants a state-based exchange in partnership with the federal government, and we will be picking up the other pieces. So part of the dollars are for that. Part of the dollars actually are about $200 million are directed toward increases and enhancements in the Medicare and Medicaid programs themselves. So the overall administration of these two efforts, where we have about 118 million people currently enrolled in either Medicare or Medicaid and need to continue to update. I would tell you, Mr. Chairman, even with that additional request, our overall administrative costs for the largest insurance programs in the world are running just under 3%, even with that billion-dollar increase.
That's very impressive. Thank you.
Chair thanks the gentleman. The committee will stand in recess until the end of the last vote. We'll reconvene immediately. And the chair recognizes the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for questions.
Thank you, Mr. Chairman. Secretary, welcome back to our committee. Got a lot of stuff to ask today. I'd only have 5 minutes, so I will, of necessity, be having to submit a lot of questions for the record, and I really would appreciate a thoughtful yet timely response to those questions. But let me follow up on where Chairman Upton was going a few moments ago. We've got the 2013 budget from the President on the the refundable premium assistance tax credits, and the line items between the fiscal year 2012 budget as submitted and the fiscal year 2013 budget as submitted are different year by year. And in fact, the total increase in this year's President's budget is $111 billion. So what has happened that accounts for this change? Are you having to reassess the number of people that perhaps might be driven out of employer-sponsored insurance onto an exchange?
Mr. Burgess, the one issue that I think has changed definitively is that there was a legislative change dealing with the adjusted gross income for people in Medicaid versus the exchange, which we feel will actually have an impact on fewer people eligible for Medicaid and more people eligible for the exchange. Much of the changes in those numbers are also, again, in the Treasury Department budget, not in our budget. I would be glad to get you a very specific answer in writing, but I'm not as familiar with some of the Treasury issues. But I can tell you that legislative change has impacted the estimates of how many people will be eligible for the exchange.
But
the Magi rule.
Fair enough, but this is a budget hearing, and that is a 30% increase. And
there is a legislative change. I'd be delighted to get additional details from the Department of Treasury.
From the standpoint of the oversight function of this committee, I think we have to have that. Now, speaking of the Treasury, can you give us a line item on how much money has been transferred to the Internal Revenue Service for their role in the Affordable Care Act?
Mr. Chairman, let me see if I can get the Treasury number up. I know that of the $475,261,000 has been spent by our department, and the rest is our partners. In terms of, Treasury dollars we have transferred $210 million to the Treasury Department. In terms of how they have allocated those funds, I cannot answer that question.
Well, that was my next question. Do you require from them for them to provide you with the allocation numbers?
Yes, we do.
And when do you expect to receive those from Treasury?
I'd be happy to get you that answer in writing. I know that it's $210 million, and I will give you the detailed report of what we have so far.
I think it's important.
We get a quarterly report from them, and I can, in terms of how they're expending and what dollars, and I'd be happy to answer that.
Well, they're your partners on this. I mean, after all, they're the enforcers who are going to enforce the individual mandate. So I think it is important that you share that information with the committee. Now, last year you were asked whether Section 1311H of the Patient Protection Affordable Care Act provided you the authority to exclude doctors and other health professionals from participating in exchange plans. Are you prepared to answer that question today?
Sir, what is the question?
Section 1311H of the Patient Protection Affordable Care Act that deals with exchanges. H starts out beginning January 1, 2015, qualified health plan may contract with, goes through A, which is hospitals. Paragraph B is may contract with a healthcare provider only if such provider implements such mechanisms to improve health quality as the Secretary may by regulation require. So are you prepared to exclude providers from the exchange? Are you developing that set of criteria? Are providers to see the day soon where they would be prohibited from participating in exchange if they don't comply with all of the things that you set forth?
Mr. Burgess, we see that issue as one that at the state level will be decided between the board of the exchange and the issuers who participate.
How about a state that doesn't do an exchange? My state is not right now, as you know. And there will be a federal exchange.
Pardon me?
And there may be a federal exchange if we can get through the problems you have with the tax code.
We will again make decisions at the federal exchange level about which issuers who have networks of their own to include based on their quality performance, based on their
But the Congress in its wisdom said that you would decide, not that the state would decide.
I'm telling you, for the federal exchange, we will be making decisions about issuers. We do not intend to reach in to a state exchange. They will be making the determinations at the state level.
Well, are you asking us for a change in legislative language to the Affordable Care Act to allow the freedom to do that?
I am not, Mr. Burgess.
But it says in statute that you will make that decision,
well,
correct?
I'm just telling you how I will make the decision. We will be working with the state-based exchanges, so they will make determinations based on their issuers. If for some reason there was an outlier, we could have a conversation, but we intend to work with the states as the law intends, so the state will set up a state-based exchange. We will at the same time be establishing a program for a federal exchange.
And will you exclude providers from the national exchange?
We will be working. This is not an issue of providers. This is an issue of which plans will be able to be operated. Plans have their own networks, and we will be working
So if you don't belong to a particular ACO, you may not be able to see your patient of long standing. Is that correct?
Mr. Burgess, that is not at all what I said. Clearly, determinations will be made about how many providers, how many plans. You might infer that from what you said.
The gentleman's time has expired.
Thank you, Chairman.
Chair recognizes the gentlelady from California, Ms. Capps, for 5 minutes for questions.
Thank you, Honorable Kathleen Sebelius, Secretary of Health and Human Services, for your testimony. You know, we're all so aware of the challenging economic climate in which we're living. However, I believe on the whole that the President's budget does strike an important balance between curbing spending and promoting the public's health. As a nurse, I also believe that I know that we cannot reach our healthcare goals without a strong healthcare workforce made up of a range of healthcare professionals. So I'd like to ask a couple of questions. If you could discuss briefly what steps have been taken in the budget to ensure that we have a healthcare workforce well-equipped, diverse, and large enough so as to help us successfully reach these goals. It's a tall order.
Well, I think you're absolutely right, Ms. Capps, about the workforce being a critical part of this effort to transform the healthcare system. And certainly primary care providers become essential, not just physicians, but nurses, nurse practitioners, mental health technicians, dental assistants. We're very pleased that this budget continues the progress we've made. So far in this administration, we've tripled the number of National Health Service Corps providers. This budget intends to continue the training of 7,100 new healthcare providers who will be serving in the most underserved areas. And I have the privilege of meeting with some of these young people every day who are thrilled with the idea they can both provide service to their communities or underserved communities, as well as have their have their loans paid off so they don't emerge with so much debt. We are also, as you know, part of the Affordable Care Act is encouraging more providers to deal with Medicaid patients, so changing Medicaid rates to Medicare, using our graduate medical resources to focus on slots for primary care. So we're very aware of the looming issue if we are going to change from a sick care system to a health care system. The primary care workforce and an additional community care workforce is essential, and we're trying to use all the levers that we have, many of which were part of the Affordable Care Act.
Thank you. And I want to just highlight the commitment to the nursing workforce, which has clearly been expanded in the Affordable Care Act, including funds to train advanced practice nurses, which can take some of the expensive care costs away and transform them into excellent care that can be delivered by nurses and others. I'm going to be circulating a letter in support of these nursing programs and urge my colleagues to join me in support of them. Just one other topic I'd like to get to. In addition to a robust healthcare workforce, we all know that improving public health requires investments in research, in development, and innovation. However, during the recent economic downturn, I've heard from researchers, many in my district, about the lack of reliable grant funding now available, especially in the private sector. And this limits their ability to pursue the kind of scientific achievements and advancements that we need. I think it also highlights the importance of the National Endowments of Health, NIH, which has traditionally been such a bipartisan issue. The President's budget only includes flat funding for NIH. However, reports indicate that management streamlining is going to free up money for 8% more grants to be awarded. Would you please expound on that a bit and explain what will go into that process and how it can actually improve the economic situation in many of our congressional districts?
Well, I certainly share your view that biomedical research is a critical component of not only saving lives, but lowering costs and improving strategies, so that the leadership at the National Institutes of Health, led by Dr. Francis Collins, I think have reorganized the resources at that very critical institution, so that we anticipate with this budget funding 672 new research grants will be funded.
Wow.
About a 7.7%, almost an 8% increase in current grant funding. As you know, there's also a new Center for Translational Science, thanks to work that we were able to do with members of Congress, that focuses on some of the most promising areas, a cure acceleration network that is in place, again, moving resources to the most promising strategies. So yes, funding is flat. This is about 40% of our discretionary budget is in the National Institutes of Health, so we found ways to make sure that those critical programs go on, and I would say that the administrative costs will be diminished and more of those resources will be focused on the research that needs to go forward.
Thank you very much.
Chair, thanks, gentlelady. Recognize the gentleman from Kentucky, Mr. Whitfield, for 5 minutes for questions.
Madam Secretary, in the Health Care Act, 2010, 2011, it provided for basically $1.250 billion for the prevention fund. And under the prevention fund, you have the authority, I guess almost unilaterally, to move that money into various accounts at HHS. So I'd like to ask you to provide to the committee for the year 2010 and 2011 the amounts of money that was transferred to which particular accounts, and then from those accounts, if grants were made to grantees out around the country, the name of the grantee, the amount of the money, the purpose of the grant, and the date of the grant. Would you be able to do that for us?
I would be happy to do that.
Thank you. Thank you very much. Now, one of the things that is a little bit troublesome to me in the President's 2013 budget is that he, in essence, eliminates part of the anti-lobbying provisions of the use of federal funds. As you know, in the appropriation bills since the mid-'70s, we've had prohibitions against using federal funds for lobbying, and to define it more specifically, prohibits using federal funds being used to influence in any manner an official of any government to favor, adopt, or oppose by vote or otherwise any legislation, law, ratification, or policy. Why would the President want to omit that from his FY 2013 budget?
Mr. Whitfield, I have to confess, I'm not sure exactly what is being referred to. I know that our FY12 budget, our budget,
Right.
and there may be other statements in other budgets that I'm not as familiar with, but our FY12 budget actually included additional lobbying restrictions, which we are actively working to comply with, which not only apply to our department, which have been in place traditionally for years, and we have complied with in terms of lobbying, but also now apply to downstream grantees who receive money through the prevention fund. So we're updating our grant language, enhancing our oversight of grantees, retraining people.
Well, I mean, I
I'm not
I
sure.
think that's commendable, and I do appreciate it, but the President, the prohibition has been very specific about using those funds at the federal level, state level, or local level. And the President explicitly in his 2013 budget allows those funds to be used at the local level. And my question to you would be, do you know why that action was taken by the White House?
Again, I would be, I will provide a more thorough answer in writing. What I've just been told by our staff is that the language that we are proposing be eliminated is duplicative of existing law, that it already exists in statute. And I will verify that and get back to you, but I am not aware of any new measures that we're talking about.
So from your perspective, you're already doing that.
That's what I...
Now, the reason I'm asking the question is because I have 7 pages here of 25 specific instances where grantees of HHS receiving money from HHS are explicitly trying to influence laws at the state and local levels relating to all sorts of issues. For example, in one town in California, Baldwin Park, they're using the grantee is using this money to reduce the density of fast food establishments and convenience stores, for example. And we have 7 pages of this, and it looks to me, just on the surface, that it's explicitly violating the law as set out in the Appropriation Act.
Again, Mr. Whitfield, the new language in our budget for FY 2012, we have not issued any new grants where that new language would be applicable. We are updating our grantee advice, we are updating, but the prospective language has not impacted any of the grants in place. We are going to comply with the law. The language that has been statutory applied to our use of our federal funds, we have also complied with that law for years. So I can assure you that the new language attached to the FY budget, and it did go beyond statutory language, is one that we are currently updating and updating grantees about, but there have been no grant releases where that new language would apply.
Well, Mr. Chairman, I might just make the comment that it was my understanding that this prohibition also applied to FY 210 and 211. So, but thank you very much.
Not by grantees,
Chair.
Mr. Whitfield. It applied to us, but not our grantees.
Okay.
Chair, thanks, gentlemen. The gentlelady from Illinois, Ms. Schakowsky, is recognized for 5 minutes for questions.
Thank you, Mr. Chairman. Just in regard to family budgets, I wanted to point out and thank you for the fact that 54 million Americans were provided at least one preventive service in 2011 through their private health insurance plan for no cost. And I think that the consequences of that are probably priceless in terms of colonoscopy screenings and flu shots and all the disease that's been prevented. So this is one of the consequences of the Affordable Care Act. But I also wanted to tell you that I had the privilege of going out with the Fraud Prevention and Enforcement Action Team on a drive around, which is very interesting, where there's this real effort to make sure that we're spending all the taxpayer dollars correctly. Although we didn't have anything quite as exciting as what we learned earlier this week about a Dallas doctor arrested for a shocking $375 million in health care fraud schemes. So what I wanted to ask is how the Affordable Care Act contributed to greater oversight and enforcement, and what kind of additional fund, how much money was found through that effort, that's it.
Well, Ms. Schakowsky, I think there's no question that the Affordable Care Act contains provisions that are probably the toughest anti-fraud provisions ever in the history of the Medicare program. Criminal penalties were enhanced, civil penalties were enhanced. We were given tools to re-credential providers in some of the most fraught-ridden areas, new resources for these law enforcement teams that are a Justice Department, HHS partnership on the ground. We now have teams in 7 cities. We're expanding to 9. We intend to continue that. Probably as important as anything are the resources that allow us to, for the first time ever, catch up with the private sector and put together a data system where real data is pulled together in one time. In the past, 12 different billing systems had various parts of CMS billing data, so you could never identify the provider in Texas in one space. It was coming through too many portals. So data analysis is now, in 2 years, significantly better than it was in the past, and we now have a predictive modeling system to look at billing billing anomalies and be able to target our resources on the ground to immediately investigate and stop money from going out the door. So the Attorney General and I were able to announce at a couple of weeks ago that $4 billion, the largest amount ever, came back to the taxpayers and to the trust funds because of these anti-fraud efforts. And yesterday alone, as you identified, a provider, on Tuesday in Texas, a provider was arrested who has been fraudulently billing, we think, 28 or 29 home health agencies. We knew that that was an area fraught with problems, and we targeted that area, used the new analytics, identified this provider, but I think it's the first of many, many that will follow.
So did the additional resources and tools in the ACA, was it responsible for this increase in recovery, the $4 billion that were recovered?
I think it was enormously helpful. There is an ongoing underlying fraud program, but the new resources and the new tools we have allowed us to, for the first time, put together some of these technology advances that really have been used by the private sector very effectively for a long time, but missing in our critical healthcare programs.
In the moments remaining, there are 2 issues that I would like to work with you and your staff on. One is Medicare beneficiaries are often designated as being in the hospital on an outpatient observation status. And they can be in the hospital up to 3 days or whatever under that status. And they're not really admitted as an inpatient. And this affects when they are sent to a nursing home or put in an ambulance. And often they don't really understand what observation status is. You're in a hospital bed, you think you're in the hospital, you think you have full insurance coverage. I'd like to work with you on that. That's,
Be glad
I
to
think,
do that.
and the other is the important information of Hospital Compare that is a useful tool for consumers, but there's also the feeling that some of the safety net hospitals, for reasons, for example, dealing with non-English speakers, that their ratings get lowered, and that concern has been brought to me. I'd like to work with you on. These are little tweaks that I think we can fix. And I want to thank you for the fact that you are working with the states, you are working with members of Congress to make this a better bill and a better policy. Thank you.
Gentlelady's time has expired. Gentleman from Michigan, Mr. Rogers, recognized 5 minutes for questions.
Thank you, Mr. Chairman. Madam Secretary, thank you for being here. As I've been working closely with my Democrat colleague Anna Eshoo on the BARDA reauthorization bill, I would hope that we could submit some questions for the record. It's very important to us. I know it's important to you.
That would be great.
And we'd look forward to working with you on that. In the 2013 budget, how many employees are dedicated and committed to getting the healthcare law up and implemented and coordinated with the states?
I do have those numbers here. If you could give me just a moment to make sure I give you the accurate number. We have 210 people in the division that is specifically working on exchanges, health insurance reform, and others. We have about another 146 working on the parts of the Affordable Care Act relating to Medicare and Medicaid, and then some department-wide folks who have picked up basically some of this effort. So about 800 people throughout CMS are actually dedicated to this effort.
Do you expect that number to rise in future budgets just for the implementation and management and regulatory administration of the healthcare law?
Again, this is an FY13 number that we are supporting, so it includes any increase that we're seeing right now. A lot of what we're doing, I think, is covered by the folks that we have.
Okay. So my concern was when the chairman went through and there's no federal state exchange rule, there's no, for states, excuse me, there's no federal exchange rule, there's no guidance and rule on what it is, an accredited health care plan, nothing that outlines benefits. We have about 18 months. And my concern here is, and I understand what you've been saying, but we have insurance agents who have been a bastion for small business being laid off. Matter of fact, I had 150 workers at one company, 30 of which were in my district alone. We think there are thousands and thousands across the country because I think the medical loss ratio rule is wrong. We have a very bipartisan effort here to fix it. Can you commit to fixing that today?
We are following the guidance from the very bipartisan National Association of Insurance Commissioners. We adopted their rule on the MLR, and we intend to stay with their rule.
So it's okay that we're going to continue to lose these jobs, and we're losing them today. We're going to lose more tomorrow, and these are the very people who are going to try to make some sense out of this massive set of rules that's only going to give them a matter of months before they are fined by the federal government. You understand why I'm concerned, I think?
Well, I think that there is a slight mischaracterization about our progress on the rules. We do have a proposed rule that is out, has been for months, on the framework of the exchange, on
but I understand
Medicaid.
That,
we have a very detailed bulletin
to reclaim
on
my
essential
time, and I
health
get it, I've
benefits.
heard your answer on that earlier. That does nothing if you're the person who actually has to raise the money, sell the product, raise the money, hire the people. A proposed rule does nothing for certainty for me, nothing. And so here's I guess my point. It doesn't seem like there is any sense of urgency about what's going to hit these very companies who are fighting for their very survival. And the one sector of that was at least going to give them some guidance are now eliminated. The federal government, by that law and by your rule, eliminated these broker agents from even having the opportunity to show up at the small cafe and say, let me guide you through this before you get slapped with a $2,800 fine from the federal government.
Well, there is no elimination of brokers and agents, and having served as insurance commissioner, I can guarantee you that I think they are valuable folks.
That's great, except that they're losing their jobs today.
The medical loss ratio in no way eliminates brokers and agents. It didn't define broker and agent as health-related
so they are eliminated
costs.
through the back door. And Secretary, that's what concerns me.
Exchanges at any point along the way can...
We ought to at least just be frank with each other and admit the fact that these brokers are going away. Now, yes, the law didn't directly say you're going away. The impact of this law is they are going away. Very, very concerning. Let me get to the second part here. I won't have much time left. 30% of doctors, according to the AMA, have already said they're restricting the number of Medicare patients in their practices. 2/3 of physicians have looked into opting out of Medicare for treating patients. We see this huge cultural shift in the practice of medicine. They are selling to hospitals at an alarming rate. Costs go up. They are reducing the number of appointments per week for senior citizens, and they're stopping to take new patients. How are you going to stop this and fix this for the future? This is a disaster for our seniors, and it's something I hope you're spending a lot of time trying to get right.
Well, I think the best way to actually make sure that the 97–8% of doctors who currently have contractual arrangements with Medicare continue those contractual arrangements is a long-term discussion and actual fix of the payment rate, which over the last 3 years expires a week at a time, a month at a time, a year at a time. The President has proposed in his budget and paid for in his budget a 10-year fix for the sustainable growth rate. That is the biggest issue that I hear day in and day out from physicians practicing, is they don't know if they're going to get paid. Being a good payment partner for the 48 million Americans who rely on Medicare benefits, I think, is the most essential thing, and we would love to work with Congress to actually get that done long-term.
I would agree with you on that. Also, if you talk to those doctors, the Medicare health care bill has made that almost impossible for them to survive.
The Medicare health care bill?
No, excuse me, the health care law, which is why you see this cultural shift in the way medicine is practiced. And I hope that you get a sense of urgency on this, because people are impacted today. Thank you. I yield back my time.
Gentleman's time expired. Chair recognizes the gentleman from New York, Mr. Engel, for 5 minutes for questions.
Thank you very much, Mr. Chairman and Madam Secretary. I want to echo the remarks that Mr. Waxman made. I think you're doing a fine job as Secretary, and I want to thank you, my constituents, for the job and the good work that you do. I am very proud of the fact that my state of New York trains the largest number of medical residents in this country. We have over 15,000 residents developing all kinds of life-saving skills in our state as of 2010, and New York also trains the largest number of primary care physicians in the country. Given the increasing age of our baby boomer generation and 32 million newly insured Americans projected to enter into our healthcare system in the next few years, I'm concerned about the significant physician shortage that this country is facing. So I want to echo the statements that Mr. Pallone made earlier. I was disappointed to see that the President's budget included a 10% cut to indirect medical education funding and a $177 million cut to children's hospital graduate medical education funding. I think we need to be training more physicians and adequately supporting our teaching hospitals, not cutting their funding as they strive to train more providers. Hospitals will already see significant cuts to bad debt and dish payments, which disturb me greatly because we fought for dish payments for New York in the Affordable Care Act. So as a result of H.R. 3630, the Middle Class Tax Relief and Job Creation Act, bad debt cut and dish payment cuts are there. So I would just ask that the administration reconsider additional cuts, especially when it comes to training our physicians.
Well, again, I share your feeling that a critical piece of this puzzle for the United States, having better health care, better patient care, better health, is certainly a robust workforce focused on prevention. And so we would work with you to make sure that we're using all of the assets, all of the resources to do just that.
Well, on prevention, one of the best parts of the Affordable Health Care Act, I think, was the establishment of the Prevention and Public Health Fund. I think that should be a priority. And I was also disappointed to see that significant reductions were made to various HHS agencies, including the CDC, as part of the budget request. The rationale which we read, it was provided, was that the preventive fund would help fund these programs, the prevention fund would help fund these programs facing cuts, but the point of the prevention fund was to add to the budgets of various public health programs, not to just supplant their existing funding. So given the FY 2013 budget request, and in light of the fact that the Middle Class Tax Relief and Job Creation Act cut over $5 billion from the prevention fund, I'm concerned that we won't be able to fulfill the goals of the prevention fund. So could you please explain how the various programs facing cuts, especially those at the CDC, will be impacted given the payroll tax extension legislation, which is now law?
Well, I think that we are eager to not only have the basic programs of the Centers for Disease Control and Prevention continue on. They're vital. They're vital to states around the country. They're vital to the health of all Americans. And some of the prevention funding, you are correct, is paying for those ongoing programs. I would say that also there are some innovative and new programs that are showing great promise that also are part of that prevention funding. And we are going to, now that we have an outline for the further reduction of $250 million, be working closely with Congress to make sure that these initiatives don't take even more disabling cuts. Unfortunately, at the state level, as you know, Congressman, the states have made some serious reductions in their public health budgets. So we are really trying to not only make sure that the national efforts go forward, but that the state workers who are embedded in state departments across this country doing vital public health work are also continued.
I want to quickly mention dental care. In a report, the Pew Center report, says that preventable dental conditions were the main cause for over 830,000 emergency room visits in 2009, which is a 16% increase from 2006. And in New York, we estimate $32 million was spent treating children for dental-related ailments in emergency rooms in 2008 alone. I introduced H.R. 1606, the Special Care Dentistry Act, which would require Medicaid programs to provide dental services to age-disabled and blind beneficiaries. And I'm just wondering, is HHS working to address the shortage of dentists in both our urban and rural areas, and how can we encourage more dentists to serve children and vulnerable adults on Medicaid?
Well, Congressman, we would be really eager to work with you on this. It is an enormously challenging problem. I think more so than virtually any other provider group. We see a great shortage of dentists who are willing to participate in the Medicaid program. We're working actively with states and others to figure out strategies to engage more dentists, but I would say that we would love to have your strategies, your ideas, because it is a challenge in virtually every part of the country, rural and urban, where we see this lack of providers who actually deliver incredibly important health services.
Thank you, Madam Secretary. I'll be in touch with your office on this and another bill that I've introduced about Moms and Babies Act. Thank you.
Gentleman's time has expired. The chair recognizes the gentlelady from North Carolina, Ms. Myrick, for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Madam Secretary, for being here.
Sure.
I want to go back to the Medicaid expansion issue again. I know Dr. Burgess touched on it a little bit, but beginning in 2014, under the health reform law, it will expand to include all non-elderly individuals with incomes below 133% of the federal poverty level. And that accounts for more than half of the newly insured population under the law. The CBO, Congressional Budget Office, estimates that by 2022, federal outlays for Medicaid are expected to total $605 billion, more than twice the 2012 amount. Obviously, many millions of new people would be covered by Medicaid at that point, but it certainly is a pretty disastrous budget outlook. So, as you know, the president's budget forces about $60 billion worth of additional Medicaid burden onto states. And states already can't afford their Medicaid programs. I know the problems we have in North Carolina. So long as the administration doesn't allow the states more flexibility and insist on enrolling these millions of new Medicaid recipients, how are we going to afford as a country double spending on the program in less than a decade? And I don't see that the budget really addresses that this year.
Well, Congresswoman, the Affordable Care Act laid out a program, as you say, that in 2014, regardless of where an individual lives in the country, the Medicaid enrollment eligibility will be identical, so that individuals up to 133% of poverty will qualify for Medicaid. Those up to 400% will qualify for tax credits in the exchange program. The vast majority of those new enrollees are paid for by the federal government. They do not add to the state budget. In fact, the first several years, it's at 100% federal funding. It decreases over the first 10 years so that the highest level a state would be paying for those additional enrollees is a 10% match.
But even
the Congressional Budget Office estimated that actual state expenditures on Medicaid populations would go down, not up. And states will also be saving what's estimated to be about $80 billion that they're spending on an annual basis right now in uncompensated care, having a payment system under a lot of the individuals who come into community hospitals, who come into the health system, but have no payment strategy whatsoever. So
well, most of that money is paid by us, the federal government. When we pay the hospitals, the states don't pay that.
We pay some of it, but I can guarantee you, as a former governor, states pick up an enormous amount of that uncompensated care at the state level also.
Right. I yield back, Mr. Chairman. Yes, I will.
Madam Secretary, let me just ask you, because when the President came out announcing the compromise a couple of weeks ago...
I'm really having trouble. I'm sorry.
When the President came out and announced the compromise on the conscience in contraception a couple of weeks ago, he described that he wanted this to be free. I got to tell you, I was a little taken aback by the President's seemingly superficial knowledge of health economics. So have you tried to help educate him when things are free that they're really not free if they have health care or medicine stamped on the side of them? Even assuming you could get the active pharmaceutical ingredient for next to nothing, which under some generic scenarios you might if you were willing to impose a formulary on all the patients in the country, you still have to involve a doctor's office. A doctor's time is still involved with evaluating the patient and writing the prescription. A doctor's still going to be required to manage that patient, hear about the complications as they occur, answer their phone calls at 2 o'clock in the morning. And the doctor still has to buy liability insurance. So none of those things looks free to me, having practiced medicine for 25 years. Have you tried to help educate the President on the fact that health care is generally not free?
Mr. Burgess, I think what the President was referring to, and I think he understands the economics of the insurance industry very well, is that this directive, first of all, in the law, is to insurers. And in an insurance pool, there is a balance of risk. What is estimated by actuaries, by federal actuaries, by company actuaries to be free is the provision of contraception to women balanced against unintended and in some cases unhealthy pregnancies. That is not only a no cost, but estimated by National Business Group on Health to be...
Why did we have to interfere? And obviously it was in the marketplace in that instance. I yield back, Mr. Chairman.
Thank you, Chair. Thanks to the gentleman, and recognize the gentleman from Georgia, Dr. Gingrey, for 5 minutes for questions.
Mr. Chairman, thank you. Madam Secretary, thank you for being here this morning. Ranking Member Waxman was quoted in the Hill newspaper yesterday as saying, and this is a quote, IPAB is a useful backstop to impose some discipline on Congress to stop out-of-control Medicare health spending. Do you agree with that statement?
I do.
Does the President believe we need to save the Medicare program from bankruptcy like Ranking Member Waxman obviously does, and you obviously do?
I think the President believes very strongly, which is why he's proposed in this budget and supported
yes,
the aspects of the Affordable
and my time
Care
is
Act,
limited, so a yes or no is fine
be,
on this, and your answer to that is yes, and I thank you for that, Madam Secretary. I know the
didn't
President
give you
has
an
begun
answer,
using
sir.
a slogan, we can't wait, to highlight congressional inaction really on many issues. Tell me this. Should we take Ranking Member Waxman's advice and start showing discipline to reform Medicare this year, or should we tell our seniors to wait until after the next election? Yes or no?
The President's budget has a very positive proposal for Medicare, which not only ensures that the 48 million people have the benefits that are committed to them, but that we continue to slow the growth rate, which has happened every year since the
well, I
Affordable Care Act
understand
was
that,
passed.
and my time is limited, so let me just say this. I ask you the question, does the President think that we need to address this issue now, or does
He would ask that you pass his budget, yes, sir.
And the answer is yes. Thank you. Are you aware that the CMS actuary predicts that the Medicare program could become bankrupt as early as 2016?
Mr. Gingrey, I think that, again, action is required. We are taking that action. We'd ask you to pass the budget, which has additional slowdown in the growth rate, adding another 2 years to the trust fund. As you know, the Affordable Care Act added an additional 12 years to the trust fund, and we would love to engage in a more comprehensive discussion as long as we don't blow up the benefits that 48 million people rely on, which seems to be the alternative plan.
Madam Secretary, I think I just heard you say that the Affordable Care Act according to the Medicare trustees, adds another 12 years.
It was according to the Congressional Budget Office.
According to the CBO, an extra 12 years. Well, you know, and I think this is possibly based on, in part, Madam Secretary, with all due respect, upon your belief that $500 billion in cuts to Medicare under the Affordable Care Act, Obamacare, can be spent twice, and other disingenuous accounting gimmicks. What do you say to that?
This was not our number. It was the Congressional Budget Office number, sir, and also numbers that are included in the Republican proposal that was put forward last year. So there seems to be some bipartisan agreement that we could slow the growth rate of Medicare by $500 billion over the next 10 years.
Well, let me
Republicans and Democrats.
Thank you, Madam Secretary. Let me shift to the issue of the individual mandate. In December, actually December 14, 2010, editorial in the Washington Post, you wrote with Attorney General Holder, and here's what you stated: it's essential that everyone have coverage. Imagine what would happen if everyone waited to buy car insurance until after they got in an accident. Premiums would skyrocket, coverage would be unaffordable, and responsible drivers would be priced out of the market. In your opinion, if the individual mandate is found to be unconstitutional by the Supreme Court, would premiums skyrocket, or would the cost curve for PPACA remain unchanged?
I can't speculate about that, but I'm confident that given the review by the majority of justices who have looked at the bill, that the Affordable Care Act will be found constitutional.
Well, that really wasn't my question. So in your opinion, is the individual mandate the linchpin to the other insurance reforms in the bill? I
think having everyone included in the insurance market is an essential component.
So in other words, the individual mandate is essential to ensuring that everyone have coverage, and the remainder of the bill, of course, would not work effectively without that coverage.
I didn't say that, sir. I think it's an essential component of the bill. It's
close enough, Madam Secretary.
Sir,
Thank you. Let me ask you this question about Medicaid.
Could I answer your question or not?
You did. I thank you for.
I did not.
I thank you for your answer, and I've only got 15 seconds left. But let me address Medicaid, and this is going back to what Representative Myrick addressed, but taking a step further. Can you assess the impact of the provision of PPACA requiring states to raise Medicare primary care physician rates up to the Medicare level in 2013 and 14 with federal funding for states and doctors, especially in 2015 when the requirement and the funding goes away resulting in an inevitable cut to their reimbursement. Have you thought about that?
We would hope that Congress would work with us to make sure that that cut does not occur in future budgets.
Mr. Chairman, can I just, Mr. Chairman.
Madam Secretary, thank you, and I yield back.
Mr. Chairman, I just want to ask, I think that Mr. Ging was asking questions, then not giving the Secretary the time to answer them. I know that he only has 5 minutes, but I really think if she feels that she needs an opportunity to answer these questions, I don't mind if, we give her another
the gentleman, I think I need to respond to him, Mr. Chairman. You make a statement in regard to my approach. And,
exactly.
Mr. Pallone, I think you spent 4.5 minutes of your 5-minute allotted time giving a speech. So if I ask questions and I want a yes or no answer, I expect a yes or no answer. It's my time.
Yeah,
it's not hers. It's mine. She gave her opening 5 minutes.
I understand, but if you don't give her an opportunity to answer the question and then you go back and suggest what she said and she disagrees that she said that, I mean, it's really not an opportunity for her to respond, in my opinion.
Chair thanks the gentleman and recognize Dr. Cassidy for 5 minutes for questions.
Hello, Madam Secretary. How are you? That's just a
that's just a yes greeting. Or no question, or?
Believe me, that's a greeting, not a true inquiry. I can imagine how you are. Listen, you said something earlier to Ms. Myrick, which I, was intrigued by. You suggested that under the ACA, that Medicaid costs for states will decrease. Now, I know I heard that. The reason I find that curious is the New York Times just had an article speaking about how Medicaid costs have gone from 21 to 23 or 24%, expected to rise further. There is a blog, EdWatch, Education Watch, which is, obviously not even part of this fight, except that they're saying that they anticipate continued crowd out of funding for education by the money required for Medicaid expenditures. In my own state, even though you speak of the newly eligible having 90% coverage and at some point falling off, or 100% falling off to 90, my own state predicts, Louisiana, that there will be $7 billion state general funds required to comply with the ACA over the next 10 years. We may quibble whether it's $7 billion or $5 billion, but it is a significant expense. Now, I say that in context, and if I interrupt, I'm not trying to be rude, it's only because we have limited time. When you mention that the ACA is going to save the state's money, that seems to be contrary to objective analyses from those not connected with government.
Well, Mr. Cassidy, I would love to get you a more detailed answer, but I can tell you that part of what is going on is overall Medicaid expenditure and state portion of Medicaid expenditure, two very different numbers. Overall, Medicaid expenditure will go up with a number of newly insured Medicaid beneficiaries. What I was referring to is the state share of that newly insured
so
population.
If I may, absolute dollars will increase even if the state's percentage of that total spending decreases.
That's correct.
But absolute dollars will still increase.
Absolute dollars, certainly, sir.
Now,
if we pay 90% of the cost, I mean, the
for the
absolute
newly
dollars
eligible.
are going up.
Now, the next issue that arises, though, of course, this is important. I'm a doctor that works in a public hospital for the uninsured, and I always point out that when more people are put on Medicaid, my lines get longer because the Medicaid dollars spread more thinly. And there's California is kind of like a case study in this right now. Just for everybody, you and I know this, but they receive, $2 billion a year for the next 5 years to expand Medicaid coverage. Now they're paying, but since then their deficit has caused them to now decrease payment to physicians. Mr. Engel spoke about dentists, to $12 a visit. That providers have filed lawsuits to stop this, but your administration, your office has filed a friend of the court on behalf of California, while acknowledging that low reimbursement does affect access. So I've always been struck that we have the form of insurance without the power of it. Can you respond how if California is paying a dentist $12 to see somebody, we don't really have access? How do we defend that, number one? And number two, how will that improve under the ACA?
Well, I think the reference that Mr. Gingrey made to the increase for Medicaid providers to Medicare rates is part of the strategy. We understand that
now, of course, that doesn't affect dental because dental is not a Medicare-covered benefit. And so dental, I presume, will stay at $12.
Oh, I'm sorry. If we're yes, if it's about dentist,
just as heterogeneous.
Yes.
It doesn't cover specialists, for example. It won't cover many other entities. It's just the primary care in particular.
Well, it covers primary care.
And that's for 2 years, correct? And then it reverts back to the state.
It is built in for 2 years in terms of the overall budget. But there's no question, I think, that the concerns about provider rates and Medicaid are ones that we share. As you know, the court case was...
I know we share that, but how can the ACA make it better if it is, one, increasing cost as an absolute dollar? California is already going bankrupt, which is acknowledged by the administration, and yet somehow as we increase absolute cost and put more people on, we're going to somehow improve rates. I don't follow that.
Well, I would say a lot of those folks right now are entering the healthcare system at various points with no reimbursement strategy whatsoever. So Medicaid rates may be too low in many instances, but I would suggest that it's better than no rate at all, which is being absorbed in some way in those same budgets that you're talking about.
$12 a doctor's visit is not. Fair statement? I mean, $12 is way below the threshold for somebody covering their cost. And so, again, it seems as if the ACA is providing the form of insurance without the power of it.
Again, this is, as you know, a state-federal partnership. Decisions about provider rates are made at the state basis. We are trying to work with states to make sure that they don't deny access to beneficiaries based on slashing provider rates.
It seems inevitable at the policies, but I'm out of time. I yield back.
Chair thanks gentlemen and recognize the gentleman from Kentucky, Mr. Guthrie, for 5 minutes.
Hey, thank you very much. Thanks for coming this morning. Yeah, I kind of want to touch on what my colleague from Kentucky, Congressman Whitfield, was talking about on the grants, the community transformation grants, and there is evidence they're being used to advocate or lobby pending positions, and I would agree that if you look at the language in the budget, you're striking the language that was put in the Appropriations Act, but you do leave no part of any appropriation contained in this act shall be used to pay the salary expenses of federal, state, but you do leave in for local. It's Congress or the state legislature, but you strike local. So you take that language out. So it seems that the proposal would grant access to the local because it says in the law that no money shall be enacted by Congress without expressed authority by Congress. So it appears the way I read this that you're asking for authority to do local. But anyway, but the current law, the way I read it now, that's going forward. Obviously, it's not enacted because it's a proposed budget. But the grants were put out under the existing law, as you said. And I think you said it applied to you but not the grantee when at the end of his comment.
Pardon me?
You said that the language applied to us, I guess meaning the government, but not the grantee. I'm not sure exactly what you meant by that. That's why I was going to ask you on that.
The original language that has been part of the law that we have administered and had our grantees administer applied to grantees lobbying the federal government. That has been prohibited. That's part of the underlying law. What was added to our appropriation bill in 2012, and what I was trying to explain is that no new prevention grants have been issued under this new language, and we are retraining grantees, is that a prohibition for grantees to lobby at the local level or the state level is now an additional piece of the law that was not part of the underlying statute. So that's new. We will administer the directives to grantees to comply with that. There have been no funds that have been issued under the new law, and I think the pages of examples which began to be recited were grantees who are lobbying at either the state or local level, not lobbying the federal government.
Okay. Well, it says in not the current law that you cannot use the grant money intended to design or influence in any manner a member of Congress, a jurisdiction, or an official of any government to favor, adopt, or oppose, or vote otherwise any legislation, ratification, policy, or appropriation. So I don't think it just limits. Current law doesn't limit you to Congress. It's any lobbying. And U.S. Code 1913. So the point is, if that's the way I read it, it says it says a member of Congress or jurisdiction or any official of any government or an official of any government to favor or oppose, vote or otherwise. And maybe that's the misunderstanding, because in the Recovery Act, on the website in the Recovery Act, one is Connecticut said a grassroots coordinator who spent 163 hours establishing community support by educating and advocating adoption of smoke-free policies. There's several, just a couple. In Idaho, to address obesity through nutrition, and it says working for proposals in the 2012 state legislature for vending machines for schools, and I can give these to you. But and then in the grants, so that was the Recovery Act money. Now it's gone to community transformation grants, and the Department of Minute that's been approved, actually in their grant proposal says they want to pass at least 70 regional local institutional policies to enhance affordability. And the New York Public Fund says they want to tax on lobby for local, or they say advocate, but lobby for a tax on sugar-sweetened beverages. Having said that, my reading of the law is that it's banned on any form of government. Is the department think it's only federal government?
Again, Congressman, I apologize. I do not have the existing statute here. I would love to answer this question in writing. I can tell you FY12 appropriations through Congress that we just have added new language.
Right.
The new language, which was not part of the underlying law, applied to grantees lobbying at the local level. So
I accept you have it granted based on what the language is the last
underlying law
appropriation.
clearly didn't cover some of what is covered in the new language.
Well, that may be where I'm agreeing with you that the money that you haven't seen grants out with the appropriation language, Section 503, but I think the existing law, and maybe that's where because it says to me, and I know you have a chance to read it, but and I agree with you, you need the time to read it, but it says any member of Congress, a jurisdiction, or an official of any government. So I think that would be city governments, state governments, and if y'all don't think that's in case, I'd like to have it in writing what your position is on that.
I would be glad to
Appreciate
answer
it.
that
Thank you.
Chair thanks the gentleman and recognize gentlelady from Tennessee, Ms. Blackburn, for 5 minutes for questions.
Thank you, Mr. Chairman. Madam Secretary, thank you for staying with us to take these questions. I want to ask you about Section 220. And we had Section 220, the President supposedly was...
Section 220 of
the Obamacare bill. You know,
Affordable Care Act, is that
yes, ma'am.
Thank you.
It was, the President goes back to 2009 with saying, we're going to have transparency, we're going to have open government, and this was a major push. Fiscal year 2012 appropriations bill that the President signed included Section 220. This was an important thing. We're going to have transparency, going to let you know where the money gets spent on this bill. Yet, we get the 2013 budget and Section 220 has been removed in its entirety. So, we have a lot of concerns about what is happening with the transparency components and how the money is going to be spent. So I would encourage you to look at this and see if you can find out what has happened with the money that was going to be designated to transparency. We'd like to have an answer to that one if you do not mind.
I would be glad to do that.
Thank you. Appreciate that. In light of that and trying to keep track of where the money is going with this bill, you and I have talked about TennCare and the lessons that should have been learned from TennCare as the test case for public option health care. One of those I repeatedly discussed, and I know you didn't think TennCare was a traditional public option program. Not sure what we think was a traditional public option, but nonetheless, your estimates for the Obamacare bill were to be $1 trillion in spending, and now I'm looking at the figures for 2014 through 2023 as being a $2 trillion estimate. So you're already running ahead of estimates. Forbes is looking at these programs, these grant programs, being about 30% over budget. Forbes had an article out on that. So I just want, you know, our problem with TennCare, Madam Secretary, was that within 5 years, it had quadrupled in its cost over the original estimates. So how do you see this playing out, and what accommodations are you and your team making for this program doubling and then possibly quadrupling in its anticipated cost?
Well, Congresswoman, I'd be happy to try and get you an answer. I don't know what you're quoting. I don't know what it's based on, so I'd be delighted to get you a specific answer. We don't think the program will double or quadruple in costs. We tried to give as accurate an estimate as we could at every point along the way.
Let me ask you this.
2 years in, we are underspending
Okay,
a lot
let
of
me
the
ask you
estimates,
this.
not
During,
overspending.
as we worked on this legislation, I asked repeatedly if you had any example where spending these near-term, ramping up all these near-term expenses had resulted in long-term savings. To my knowledge, you had no example of any program that showed where ramping up these near-term expenses would yield a long-term savings. Were you all ever able to find an example? Because you're running over budget. You've got a budget that has increased 25% since 2008. Your estimates are running ahead of what they have been, and we are at record spending, record deficits, record debt in this country. So if you ever came up with that example, I sure would like to see it, and I've got some constituents that would certainly like to see it. Let me shift gears for just a moment. I want to go to your narrow religious exemption rule and what I think is a fee-for-faith principle that is out there. USA Today had an op-ed, an editorial in, and they made the comment that not only had you crossed the line on religious liberty, but you had galloped over it. I just have to ask you, Madam Secretary, did you all consult the Department of Justice before you made this decision?
Which decision are you referring to, Congresswoman?
Religious liberty, the First Amendment?
Which decision are you referring to?
The mandate to the Catholic,
prevention
the mandate to the Catholic churches. I think you know what I'm talking about.
We have consulted with a number of people. Did we consult before we finalized the rule on prevention?
Yes, ma'am.
With the Department of Justice? No, we did not.
You did not. Okay, thank you. My time has expired. I yield back.
Chair, thanks, gentlelady. Chair recognizes gentleman from Pennsylvania, Dr. Murphy, for 5 minutes for questions.
Thank you, Madam Secretary. I want to follow up on the Religious Freedom First Amendment issue as well. I just want to be sure. If an employer is saying that he or she cannot find it in their conscience in terms of practicing their religion, that they cannot pay for a plan or have a plan that allows for or requires provision of abortion-patient drugs, and they therefore do not provide that plan. Just clarify for me, do they pay the $2,000 tax for not having it, or do they pay the $3,000 tax for having a plan that's in violation?
There is no penalty attached to the provision of preventive care. There certainly are penalties for employers who don't comply with the law. There also is no abortifacient drug that is part of the FDA-approved contraception. What the rule for preventive care...
Ma'am, that's not true.
Well, the scientists...
Is a morning after pill or something like that an abortifacient drug?
That is
yes
true.
Or no?
It is a contraceptive drug, not an abortifacient.
Yes or no? Yes or no? Does it?
It is not an abortifacient. It does not interfere with a pregnancy. If the morning after pill were taken and a female were pregnant, the pregnancy is not interrupted. That's the definition of abortifacient.
And I appreciate that's your interpretation.
That's what the scientists and doctors
We're not
have informed
talking
me,
about
and I know you're
scientists, ma'am.
practicing
We're not
medicine.
talking about scientists here. We're talking about religious belief.
I'm telling you that,
ma'am, I'm asking you about a religious belief.
The definition of an abortifacient
in a
is
religious
incorrect.
belief, that is a violation of a religious belief based upon those within a religion. Now, let me expand on that then. So if an employer says, I cannot have this plan provided for by the employer, whether it's paid for directly or someone says it's going to be paid for by somebody else, do they end up paying the $2,000 tax or the $3,000 tax per employee?
The rule which we intend to promulgate in the near future around implementation will require insurance companies, not a religious employer, but an insurance company, to provide coverage for contraceptives for employees who choose to access that
Ma'am,
benefit.
that's not what I'm asking you about. I'm
And
asking, I'm
the-
not, ma'am, please, I'm not asking you about that. This is very important. This is a First Amendment issue, which you keep talking about these things in a different way. Let me try and help make this clear. If, because one of the things I think you say is that if a organization has people within that organization that are not part of that same faith value system, that they therefore couldn't claim an exemption. Am I correct in that? So let's say Catholic Charities has other employees who are not Catholic, or a Jewish hospital may have other doctors who are not Jewish, or Catholic Charities may provide services to non-Catholics, that they therefore could not claim a religious exemption. Is that accurate?
They don't fall under the definition that is total exemption from the rule. They will fall under the secondary rule of a religious objection to the service, and we will provide.
Under that, they would still have to provide the objectionable medical services.
Absolutely not. The religious employer who objects to contraception because of religious beliefs will not provide, will not pay for, will not refer employees to an objectionable service. On the other hand, the insurance company will provide the service to employees.
Let me make sure I understand this correctly. So if a child in school
upholds religious liberty and it makes sure that women have access to this critical benefit.
No, you're wrong. You're wrong for this reason. You know, you're setting up a rule that not even Jesus and his apostles could adhere to. Jesus was Jewish. He recruited Jewish people, tax collectors, sinners, Mary Magdalene and others, and therefore saying, you know what, because you're not bringing all Christians into this fold, you can't do this. What you're missing here is because someone else is paying for it, somehow that makes sense. If I go to a tire store, which I recently did, it was buy 3, get 1 free tires, I know I'm paying for that extra tire by the other 3 being pumped up, or someone else is paying for it by their costs going up somewhere else. It is one thing. I've searched for ways of trying to help you understand it, and I don't know, maybe the administration just refuses to understand, so therefore it can't happen. Whether or not you have someone else pay for it, or whether something else is under the guise of being free, as long as it is imposed upon someone to have this available, that is still a violation of their faith, which gets into the First Amendment. I don't understand why this isn't clear.
Well, first of all, I think the tire analogy is not quite accurate. Insurance
Well, who's
is
going to
about
pay for
a balance of
who's going to
risk,
pay for the service?
providing, we know, because it was done in the federal employee
Who pays
health
for it?
benefit
Who pays
plan.
for it? There's no such thing as a free
The
service, ma'am.
reduction in a number of pregnancies compensates for the cost of contraception. The overall plan,
So by
according to
not
the National
having
Business
babies
Group on Health,
born,
goes
we're
down,
saving
not
money.
up.
I just want to get this on the record, Mr. Chairman. So you're saying by not having babies born, we're going to save money in health care?
Providing contraception as a critical preventive health benefit for women and for their children reduces health
Not
care
having
costs.
babies born is a critical benefit. This is absolutely amazing to me. I yield back.
Family planning is a critical health benefit for
You said
women across
avoiding
this
pregnancy,
country,
ma'am.
according to the Institute of Medicine, and that's, again,
I think that's
scientists.
it's about religious freedom. Thank you.
The chair recognizes the gentleman from New Jersey, Mr. Lance, for 5 minutes for questions.
Thank you very much, Mr. Chairman. Madam Secretary, the President's budget requests the level of exclusivity for follow-on biologics, reducing it from 12 years to 7 years. And I think that might be counterproductive, and I'm wondering whether you would be willing to re-examine that. On a bipartisan basis, this committee has repeatedly indicated that it favors the 12-year period. There was a bipartisan vote of 47 to 11 on that issue in this committee.
Well, I think, Mr. Lance, this is an important and ongoing dialogue. The balance of making sure we protect research and development, making sure that companies can, in fact, make a profit when they find a successful strategy, and opportunities for patients to have an affordable option that may be life-saving is, I think, what's at risk here. And Certainly, I think there is a difference of opinion of whether 12 years is the appropriate time, whether 7 years adequately compensates companies and yet makes more cost-affordable options workable.
Thank you. I would encourage you to work with us on that. I favor
I'd be glad
the
to.
12-year, and I appreciate any work we might be able to do together on that. We're hearing from those who have to implement the new summary of benefits and coverage requirements that the time period may be difficult to meet, given the fact that employers and plans need to get this done, and if they don't comply, there are significant financial penalties. Might the department consider any sort of delay of the non-enforcement period?
Well, I think that, again, the essential health benefits are a critical component. We put out very detailed guidance because we were hearing from a lot of states, from insurers and others saying, tell us what's going on. I think the strategy of suggesting that a benchmark plan already marketed and in place in a state is a really accelerated strategy. This is not something that has to be started from the ground up. This is an ability at a state level to choose a plan, the most popular small employer plan, the federal health benefit plan, a state health benefit plan that is in place, is marketed, is priced at the state level. We made it very clear in the guidance that this is what we intend to propose. We're trying to get as much feedback as possible from insurers, from states. We've had a very robust discussion, and in the very near future, we'll be issuing the interim rule.
Thank you. Regarding the Supreme Court argument on the health care legislation, undoubtedly the Solicitor General's office will be arguing that case. Does your department also have lawyers who will be involved in the oral argument, or is it exclusively the Solicitor General?
It's the Solicitor General who will be involved in the oral argument.
Thank you. I am willing to yield back to any member who is interested in further questions. Thank you, Madam Secretary. To Dr. Burgess.
Thank you. It's very kind of you to provide a little additional time. Madam Secretary, you were here before, and we talked a little bit about the difference between a voucher and premium support, and you had some difficulty articulating a difference between the two. I'm going to try to help you because, of course, under the exchanges, you will provide a subsidy, but that subsidy is not coming in the form of a check or cash to a household. There will presumably be some sort of acknowledgement that this help is now available to you to help you purchase your insurance in the exchange, so that might be regarded as a voucher, a coupon that you could take to the exchange, and in return you get a discounted price for your health insurance. Now, premium support, I don't know, you might have your insurance through the Federal Employee Health Benefits Plan. Many people in the administration, the agencies do. That's premium support, where the FEHBP goes out and takes requests for proposals from all of these different insurance companies. There is, in fact, a bill, H.R. 360. Members of Congress are going to be required to buy their insurance in the exchange after 2014. Members of the administration, members of the federal agencies are exempted from that requirement. You, in fact, could experience the world of a voucher versus premium support by supporting H.R. 360, which would move all members of leadership staff, and the administration and the agencies from the FEHBP into the exchanges. Would that be a good idea?
We'd be happy to look at it.
I would appreciate your response.
Chair, thanks, gentlemen. That concludes the first round of questioning. We'll now go to Dr. Christensen, who's a member of the full committee, who has sat patiently since the beginning of the hearing for 5 minutes for questions.
Thank you, Mr. Chairman and Ranking Member. I really appreciate the opportunity to sit on this hearing and your generosity in allowing me to participate. And welcome, Madam Secretary.
Thank you.
Your being here gives me an opportunity to formally and publicly thank you for the unprecedented efforts that the department has taken under your leadership to end inequalities in health care and health status through your national strategy to end health disparities. On the other hand, I want to just say briefly that the 2013 budget does raise some concerns about our ability to meet the goals that you've set out. But I also know that across the budget, President Obama has worked with agencies to, wherever there are cuts, to take steps to ensure that important programmatic activities are not really cut as might appear, that they don't suffer, but are covered in other ways. And 5 minutes doesn't give me the opportunity to go through those areas of concern, but would you be willing to meet with the Tri-Caucus to go over some of those areas and show us perhaps where steps have been taken to make sure that those programmatic activities have not been cut?
I would be pleased to do that. As you know, we have tried to work carefully with members of Congress who share our concern about the health disparities issues present around the country, and we have lots of strategies and agencies hard at work closing those gaps, and for the first time ever have a national strategy on health disparities that is a real action plan. So we'd be delighted to go over that with you and meet with you about it.
Thank you. And the President's budget proposes a single blended federal matching Medicaid rate. I'm sure there are different opinions about that, but I think that the time has come for the territories to have the same methodology used for setting our match. And we did have that included in the House version of the Affordable Care Act. And the Senate actually agreed to it, but we weren't able to get it done because of just technical reasons and how the bill was both bills were structured. If given the authority, would you be supportive of setting the match according to the way the states are done on the average income? Right now, we are a 50-50 match in statute, and that's very difficult. Would you be supportive of having the authority to set our match as the states have set?
Well, we'd certainly be happy to work with you. I know it's a huge issue for the territories and the islands, and we are working on that. The framework does not allow us to do that, and we do not have the budget to do that currently, so we would be happy to pursue that discussion.
And if we went into the blended rate, if that does take place, it's my understanding you need about 2 years of history to be able to make the determination. So it would be helpful. We wouldn't mind going into the blended rate if that's the way we're going to go. Just one more question. There are 2 new institutes at the NIH. One is the one you mentioned on translational medicine, and the other one is the National Institute for Minority and Health Disparity Research. One created administratively, the latter one, and the Minority and Health Disparity Institute by the Affordable Care Act. The budget for the National Institute for Minority and Health Disparities is one of the lowest of all of the institutes. And that's despite the major initiatives that we have to eliminate health disparities. Is there language in the budget, or would you accept language to bring the National Institute of Minority and Health Disparity Research on par with the other institutes? And I do know that the research centers on minority institutions that program was transferred to the institute, but even funding with it. But even that funding was insufficient to support the research centers, so it remains underfunded under the institute. So is there language that would bring the National Institute on Minority and Health Disparity Research on par with the others, or would you be willing to accept that language?
Well, again, Congresswoman, I think you've identified that the transfer, along with staff and budget, actually has significantly enhanced this whole effort over where we were 2 years ago. We would be happy to work with you around ideas and strategies for continuing improvement, but there has been kind of a big move forward, I would say, from where we were when we began this conversation.
Okay, but my understanding is it's still, it's still underfunded, even with moving the RCMI in. So we appreciate your willingness to work with us, Madam Secretary, and thank you for your testimony and your answers.
Thank you.
Chair, thanks to the gentlelady. Madam Secretary, we have one follow-up on each side, if you can stay for that.
And Mr. Markey, too.
And Mr. Markey has come in, would like to ask a question. Gentleman, Mr. Markey is recognized 5 minutes for question.
Thank you, Mr. Chairman, very much. This is my 36th year on the committee, on the healthcare committee, so it's been a long time trying to get to this point where we actually have a plan to deal with the long-term healthcare problems of our country. And amongst those includes the National Alzheimer's Project Act to deal with this very important issue that cost the federal government, Medicare and Medicaid last year spent $130 billion on Alzheimer's patients in America. Unbelievable amount of money. And that's with only 5 million Americans having it. By the time all the baby boomers have retired, the cost is going up to maybe $600 billion a year just on Alzheimer's patients if we don't find a cure for it. And it's obviously a budgetary crisis that is looming. And last week, Madam Secretary, we thank you. You issued your draft national plan pursuant to the National Alzheimer's Project Act, which I'm the principal House author of, along with Congressman Smith. And I think it's great. You know, and the one thing I wanted to talk about here today is that at NIH, there's $6 billion a year spent on cancer research, and there's $3 billion a year spent on AIDS research, but only $489 million on Alzheimer's, even though 15 million baby boomers are going to have it. We have to find the cure. And so, Madam Secretary, I congratulate you and the administration on announcing the addition of $80 million more in this coming year's budget on the research for Alzheimer's. I think that that is absolutely critical, and I congratulate you on that. And I just think it has to be dramatically higher. And if there's one thing we should just signal out and just say, this has to be spared, it's the NIH budget. That just has to go up and up and up, because the National Institutes of Health are really the National Institutes of Hope. And in Alzheimer's, there's really going to be a medical catastrophe that hits this country when all the diseases that we've been successful in helping to cure lead to people living so long that half our population winds up in retirement with Alzheimer's. It's going to be an absolute disaster, and it's going to cost us a fortune. And the second thing, Madam Secretary, is in the Affordable Care Act, I was able to include language for an Independence at Home pilot project. And there are now more than 3 times as many applicants, that is, medical institutions that are applying for those slots in order to conduct this experiment. And I'd just like to draw to your attention the fact that the VA has already had a wildly successful program that had 11,000 people in it, that reduced hospital stays by 60% and nursing care days by 80%. And so I appreciate all of your efforts in this area, but I think it could help us to telescope the time frame that it's going to take us in order to put together a program to keep people at home, share it with the institutions that are working hard in partnership to keep them at home, making the patients and their families better able to deal with the disease. So I'm just looking for a little wisdom from you in terms of what what your agency is doing, and how much of an imperative you see this for our country.
Well, first of all, Mr. Markey, I want to thank you for your tenacious leadership on the Alzheimer's issue, and continuing to raise it and make sure it's an issue that's focused on. As you know, not only is there 80 million new research dollars in the 2013 budget, there were also reallocated another 50 million in the 2012 budget at NIH. So it's about a 25% increase in Alzheimer's research. We also have proposed a portion of those funds, additional funds, not those funds, for caregiving and at-home care, because we know family care providers are the largest number of providers for family members. But I would share your interest, and we look forward to working with you on what is the long-term strategy, how fast we can get there. As you know, some timetables were set for the first time in the National Alzheimer's Plan. There's a lot of agreement that we probably need to move ahead of that pace, but at least we have a pace and a measurable pace outlined. And so we would look forward to working on getting the resources, getting the research, getting the caregiving strategies in place.
A fully implemented Independence at Home project could save billions of dollars a year if we could just get to the point where we verify what the VA has already determined exists.
Well, that's a great point, and we will definitely work with our partners at the VA too.
Thank
Chair,
you,
thanks, gentlemen.
Thank you for your great work. Appreciate it.
Chair, thanks, gentlemen, and recognize Dr. Burgess for one follow-up for 5 minutes.
Thank you, Mr. Chairman. I would just point out to Mr. Markey, while he's still here, this was one of the rare instances of bipartisanship in the Affordable Care Act where we worked with your office on getting the independence of home language refined and included. So perhaps there is hope down the road. But actually, going back to state exchanges for a moment, some states are concerned that without the final rules on the exchanges, they're bumping up against a deadline that it's going to be pretty tough for them to meet. I mean, they need these rules probably within the next couple of months if they're able to be able to finalize their issues to meet the deadline.
And they will have them shortly. We have the interim final rule out, and we intend to finalize the rule in the very near future.
So we can look for that by,
yes,
what, the Ides of March, April Fool's Day, Tax Day? What day can we
Shortly.
expect? Shortly, okay.
He said they need them in the next couple of months. They will definitely have them in the next couple of months.
And then the essential health benefits rule also will be coming out in that same very short time span?
The essential health benefits rule has not yet been proposed as an interim rule. I'm talking about finalizing the exchange rule. That will happen in the very near future. They will have the exchange rule. They'll have the Medicaid expansion rule that's been out as an interim final rule. The essential health benefits rule will be promulgated in the near future, but there is detailed guidance right now that states are working on.
Yeah, I'll just make a prediction. That won't happen until after Election Day in November, but that's just me being cynical. For a state like, let's say, for example, there's a state out there that worries about what's happening under the Affordable Care Act and really thinks the federal government's maybe going a little too far on this, so they're reticent to set up a state exchange. I mean, I can think of a state that might fall into that category. I may be going there this afternoon. So you're preparing a national exchange for those states that will not, either because they haven't had time or because they did not have the inclination, will not have an operational state exchange?
There will be a federal facilitated exchange. In some cases, operating fully the exchange for states and others.
So the federal government will step in and provide that operational control, is that correct?
Pardon me?
The federal government will step in and provide that?
Yes, sir.
Now, will that be administered through your office or through the Office of Personnel Management?
It will be administered through the CMS, we will be operating at HHS.
Both a for-profit and a not-for-profit offered under the language of the law?
No, there will not. No.
I thought the language of the law said that there had to be a for-profit.
No, I think you're talking about the co-op situation, which
no, I'm
is a
talking
totally
about the state
different.
exchanges, or the federal exchange,
There will
or
not
the public
be a
option, whatever we want to call it.
There will not be a not-for-profit. Yes, states have that option. That is not at the federal level, sir.
Let me ask you this. A lot of talk about the contraception issue and the essential benefits. When will we see, are you proposing that an institution that refuses to comply with your contraceptive mandate, what's going to happen to them?
Sir, I'm hopeful that the rule that we intend to promulgate in the very near future, which will be informed by conversations with not only religious employers, but labor leaders, women's groups, and others, and actually greatly informed by the 28 states which have a framework like we're talking about already in place, will indeed satisfy the religious liberty issues and make sure these preventive health benefits are provided.
The non-compliers going to be fined?
Sir, we'll get, as you know, this is a
Well,
situation
let me just
where
share with you something. It bothers me that for the first time in this country, regardless of what the issue is, and I personally support the issue of contraception, but at the same time, it bothers me that there might be a fine for faith. I don't think that's ever happened before in this country, and I'm concerned about the direction.
No one will be fined for faith. This is an issue dealing with
well, why
insurers.
did you propose a two-tier system? where some churches might be exempt, but a Catholic hospital might not. I mean, that sounds like that's the direction that you're going.
The exemption, which is in the original rule finalized in January, in February, is the language used in the majority of state laws which have some religious exemption. That's where we got that language. It is a definition that's in the IRS code. It's not something that we invented. It is a definition of churches and church-affiliated associations.
If a state required sterilization as a condition of citizenship, would you be prepared to do that at the federal level?
Sir, I'm not going to answer that question.
Thank you, Mr. Chairman. Before we finish up here, I have unanimous consent. Mr. Whitfield had a number of observations that he wanted entered into the record, and I would ask to enter those now under unanimous consent.
Mr. Chairman, reserving the right to object, we wanted to, I know you handed that to us, but we haven't had time to really look at it. So if we could take a look at it before we agree to unanimous consent.
All right. We'll wait until you take a look at that and recognize the ranking member, Mr. Plone, for 5 minutes for questions.
Thank you. Madam Secretary, I just wanted to give you an opportunity to address somewhat of a follow-up to what Dr. Burgess and others have said. Clearly, the matter of insurance coverage for FDA-approved contraceptives under the ACA has become controversial. Unfortunately, what I think has been lost in the debate is an understanding of how HHS arrived at the decision it's made. And I just ask you to take a few moments, I've got 4 minutes or so, to provide the broader picture, to tell us about the ACA's provisions on preventative health services and women's preventive health services, the role of the Institute of Medicine study on coverage of women's preventive health services, and the HHS's process in developing these regulations that are now under attack. I know you started to get into that with Dr. Burgess, but take the 4 minutes to maybe explain it a little more.
Well, Mr. Pallone, the Affordable Care Act had a provision that, as part of a definition of essential health benefits, various populations should be looked at. The recommended strategies for children around immunizations would be included. The strategies for preventive health that are recommended by the United States Preventive Health Services Task Force would be included. And recognizing that too many insurance plans often did not include benefits that were specifically recommended for women's health, we were asked to develop a set of preventive health services for women. We turned to the independent, scientifically driven Institute of Medicine and asked them to make recommendations to us. They came back with 8 various health benefits, domestic violence screening, mental health benefits, well woman visits, and the full range of scientifically recommended contraception services. We promulgated their rules as part of the strategy for women's health as an interim rule and added a religious exemption. And to be informed by what language should be used in that religious exemption, we looked at the 28 states which have some kind of contraceptive mandate in place right now, often for a decade or more, operationally right now, and we included language that was used by the states in the majority of cases that have an exemption. Many states don't have an exemption at all. That language was put out. It was finalized in February, and an additional accommodation was made. We announced that we would have an additional year for religious based organizations who had a religious objection to the provision of contraceptives, so that their implementation date would be deferred until August of 2013, and that we would promulgate additional rules around their ability to both uphold their religious freedoms, not refer, not pay for, not provide contraceptive coverage, and yet make sure that women who were janitors, teachers, nurses, employees, the spouses of employees, the daughters of employees, would have access to this very critical health benefit. And so we will be promulgating a rule around the implementation strategy for preventive health services, which will be a huge step forward for American women, knowing that contraception is the most frequently taken prescription drug from women 14 to 44. 99% of women of all religions use contraceptives at some point in their health lives, and that often if you purchase contraception out of your own pocket, it can be an expensive strategy. If it is provided within an insurance pool, it not only is no cost, but often reduces the cost of the pool.
Thank you very much. I appreciate it. Thank you, Mr. Chairman.
Chair, thanks the gentleman. I think that concludes all of our questioning. Thank you, Secretary Sebelius, for, again, taking time to be with us today and for all of your answers. I ask unanimous consent that all members' opening statements be made part of the record. Without objection, so ordered. Have you seen the request, the unanimous consent requests?
I think we're going to need some time. We're going to need some time.
I remind members that they have 10 business days to submit questions for the record, and I ask the Secretary to respond to the questions promptly. Members should submit their questions by the close of business on Thursday, March the 15th. Without objection, the subcommittee is adjourned.